Therapeutic modalities are cornerstone tools within the physical therapy profession. They serve as valuable adjuncts to our primary interventions of manual therapy, exercise, patient education. Their primary function is to help manage critical symptoms like pain, swelling. These symptoms often act as barriers to a patient's functional progress. By effectively modulating these symptoms, we create a therapeutic window. That window lets us introduce active, restorative treatments sooner and with better tolerance. The goal here is to move beyond guesswork with clear, evidence-informed protocols for common modalities. We'll focus on heat-cold therapeutic ultrasound electrical stimulation, so you can use them with confidence and precision. Thermotherapy, commonly known as the application of superficial heat, is a modality used to increase the temperature of targeted tissues. This elevation in temperature initiates beneficial physiological effects. Primarily, it causes vasodilation, expanding blood vessels and improving local circulation. Increased blood flow delivers more oxygen and nutrients and helps remove metabolic waste products. The result: reduction in pain, decrease in muscle spasm, decrease in stiffness, increase in soft tissue extensibility. Heat is an excellent preparatory modality for manual therapy, stretching, and therapeutic exercise. It's a simple but powerful tool for subacute and chronic symptoms. Indications are specific. Avoid acute inflammatory phase. Most beneficial for subacute or chronic pain, persistent muscle tightness, joint stiffness, for example, osteoarthritis. Apply heat just before range of motion treatments because increased extensibility allows greater gains with less discomfort. Example: moist heat pack on a stiff lumbar spine, then mobilization or flexibility exercises for chronic low back pain. Contraindications are critical. Do not apply heat during the acute inflammatory phase. First 48 to 72 hours. Heat can exacerbate swelling, increase bleeding, and intensify inflammation. Absolute contraindications: impaired sensation, compromised circulation, or peripheral vascular disease, open wound or active infection, known or suspected malignancy. Wrap a hydrocollator pack in 6 to 8 layers of toweling. Aim for skin temperature around 40 to 45 degrees Celsius. Comfortably warm, not painful. Treat 15-20 minutes, check skin at 5 minutes, and use the final 5 to 10 minutes for gentle ROM or stretching. Cryotherapy, the therapeutic application of cold functions as the physiological counterpart to heat. Vasoconstriction, narrowing of blood vessels, is the primary mechanism. By slowing local blood flow, cold helps control swelling and bleeding after trauma. Lower tissue temperature decreases metabolic rate, reduces inflammatory mediators, and limits secondary tissue damage. Cold produces analgesia by slowing nerve conduction, numbing the area, and relieving pain. It's the modality of choice in the initial injury phase. Indications focus on acute conditions: ligament sprains, muscle strains, contusions, especially within the first 48 to 72 hours. Goal: minimize hemorrhage, edema, and pain. Combine with rice or police for best results. Contraindications: known cold intolerance, cryoglobulinemia, Raynaud's disease, significant peripheral vascular disease, compromised circulation, impaired sensation, open wounds. Use crushed ice, gel, or commercial packs with a thin, damp cloth between cold source and skin. Treat 10-20 minutes per session. For acute swelling, repeat every 1-2 hours while awake. Warn patients: they'll feel intense cold, then aching or burning, then numbness. Stop if treatment extends long past numbness. Acute lateral ankle sprain in the first 48 hours. Prioritize cryotherapy within police. Rule out fracture and contraindications. Apply crushed ice over the lateral ankle with a damp towel barrier and secure with compression for 15 minutes. Repeat every 1.52 hours. Keep the ankle elevated above heart level. After 48 to 72 hours, transition to protected weight-bearing, gentle ROM, and neuromuscular re-education. Continue post-session icing as needed. Cold, compression, and elevation stabilize the acute phase and set the stage for efficient recovery. Therapeutic ultrasound, a deeper approach to tissue healing. Therapeutic ultrasound uses high-frequency acoustic energy to produce thermal and non-thermal effects in deep tissues. A piezoelectric crystal in the transducer generates sound waves, and a coupling gel transmits energy efficiently by eliminating air. Continuous ultrasound generates deep heat, up to 5 centimeters, increasing blood flow, reducing spasm, and improving collagen extensibility. Dense tissues benefit: tendons, joint capsules, scar tissue. Pulsed mode delivers intermittent bursts thought to facilitate cellular healing with minimal temperature rise. Use ultrasound where deep heating or micromassage is desired, e.g., adhesive capsulitis and post-surgical scar tissue before stretching. Never apply over eyes, heart, or carotid sinus. Contraindicated over malignancy, active growth plates, pregnancy abdomen, low back, reproductive organs, active bleeding, infection, DVT, impaired sensation or circulation, or implanted devices. Technique: choose 1 mmHg for deep targets, 3 mmHg for superficial tissues. Select 100% continuous for thermal effects. Lower duty cycles like 20–50% for non-thermal effects. Intensity typically 0.5–1.5 WCM2 for thermal treatments. Tailor with patient feedback. Treat for 5 to 10 minutes depending on area and energy needed. Keep the transducer moving continuously at about 4 centimeters per second with adequate gel to avoid hotspots. For knee osteoarthritis with deep joint line pain and capsular tightness, 1 MHz continuous, 1.0–1.5 WCM2 for 8–10 minutes, covering medial and lateral joint lines. While tissue is warm, perform patellar and tibiofemoral mobilizations, followed by low-load prolonged stretches into flexion, extension. Then progress to functional strengthening like sit-to-stands and mini squats. Electrical stimulation, or E-Stim, uses electrical currents to elicit physiological responses in nerve or muscle. The response depends on current type and parameters. TENS, mainly for pain control. NMS, for muscle contraction and re-education. IFC, often for deeper pain modulation. TENS blocks pain via gate control or triggers endogenous opioid release. NMES depolarizes motor nerves to produce visible contraction for strengthening, reducing atrophy, and improving motor control. Use TENS for acute and chronic pain to enable fuller participation in active therapy. NMES is invaluable post-surgery or injury, especially with arthrogenic muscle inhibition. IFC can help diffuse deep pain like generalized low back pain. Safety is paramount, never over the anterior neck, carotid sinus. Strictly forbidden with pacemakers or implanted electronics. Do not place electrodes over the trunk abdomen in pregnancy, malignant tissue, active infection, or regions of impaired sensation. Conventional TENS, 50–100 Hz, short pulse width, sensory level intensity for immediate relief. NMS for strengthening, 30–50 Hz to tetanize, cycle 10, seconds on, 50 off to prevent fatigue. Increase to a robust but tolerable contraction. Pad placement is critical, over the muscle belly and motor points. Explain expected sensation and monitor skin under electrodes. For early post-op quadriceps inhibition, place 1 pad proximally, jars laterally, and 1 distally medially, over VMO. Set 35–50 Hz, 300–400 US. Cue the patient to contract with each 10-second on cycle for 10 to 15 reps several times per day, integrating quad sets, straight leg raises, and terminal knee extensions. Active participation is crucial for neuromuscular re-education. The true value of modalities emerges when they're integrated into active rehabilitation, never as the sole treatment. Identify the primary impairment: acute swelling and pain, chronic stiffness and limited mobility, poor activation and weakness. Let that guide selection. Cold on an acutely sprained ankle limits edema and enables early gentle ROM. Ultrasound to a stiff shoulder capsule, then immediate mobilization and stretching. NMES to the quadriceps followed by voluntary sets and sit-to-stands to translate into function. Match to healing phase, cryotherapy in acute, heat or pulsed ultrasound in subacute. Continuous ultrasound or heat in chronic to prep for loading. Document parameters and response: temperature, intensity, duration, frequency, pain rating, ROM, contraction quality. If a modality doesn't yield meaningful change in a few sessions, stop it and refocus on active therapies. Before application, confirm indication. Screen contraindications. Ask about pacemakers, pregnancy, cancer. Verify intact and normal sensation. Inspect skin and circulation. Verify parameters and technique. Always use coupling gel for ultrasound. Monitor continuously. For thermal modalities, check skin at 5 minutes. For E-Stim and ultrasound, maintain verbal check-ins. If adverse signs occur, stop immediately. Use modalities wisely, safely, and with purpose to enhance, not replace, hands-on care, exercise, and education, catalysts for lasting functional recovery and independence.